Each year, CMS publishes an advance notice of methodological changes for the Medicare Advantage and Part D Star Ratings program. After reviewing comments and questions, CMS releases the final rule in April, outlining the confirmed measure and policy changes that will go into effect during the next star rating years. Today, we'll break down what you need to know about the Medicare Advantage and Part D final rule, including the codified and uncodified measure changes, potential timelines for publishing new rules, and how plans can prepare for the unknown. We know these key dates and details can often be tough to keep track of, so we prepared a resource for you. I welcome you to scan this QR code on your screen to download Cotiviti's CMS Star Ratings calendar as a reminder of the proposed, deferred, and confirmed changes to the CMS Star Rating system. We keep this calendar consistently updated throughout the year, so you can bookmark this tool for an up-to-date reminder of proposed and confirmed upcoming changes to the CMS Star Rating system. You'll also note that Marge and Danny have color-coded the bullets throughout their presentation today to match this calendar's purple for confirmed, green for proposed, and pink for deferred changes. I'll also put this back up at the end of today's session if you'd like to scan it then. With that, I'll turn it over to Danny to get us started.
Thanks, Cassie. As mentioned, CMS officially released the final rule on April 4th, 2025. Only a few changes were codified during this final rule. Let's discuss what was codified, deferred, and what was considered still uncodified in the final rule. In other words, what proposed changes could still be codified in the future. As of April's final rule, there were no new updates and/or changes for these measures in the STAR Year 2027 program. To recap what we know about the previously codified rules, the care for older adults, pain assessment, and standalone medication reconciliation post-discharge measures are removed. 3 measures have been added with a weight of 1. The care for older adults functional status assessment, the concurrent use of opioids and benzodiazepines, and the polypharmacy use of anticholinergic medications in older adults measures. The only major change mentioned during the final rule was that the Health Equity Index was renamed to Excellent Health Outcomes for All, and/or EHO for All. This name better captures the goal of ensuring exceptional care for all enrollees. There were no new changes, removals, additions to the rules used to calculate this reward in the Star Ratings 2027 program. To recap what we know about EHO for All, the reward is replacing reward factor. It will be implemented in the beginning of the 2027 Star Ratings program. Enrollees included are members who are dually eligible or low income subsidy or are disabled. The primary focus on these groups are because these populations are at risk for poor health outcomes, and Star Ratings data shows gaps in the quality of care for these enrollees. When implemented, the EHO for All reward incentivizes improved performance among specified groups of enrollees at risk for poor health outcomes. By removing the current reward factor and replacing it with EHO for All, CMS is also incentivizing improved performance across all enrollees. This is consistent with the goal of achieving excellent health outcomes for all. The benefits of EHO for All are that health plans are now able to pinpoint members with social risk factors, incorporate social risk factors into member level reporting, track and categorize performance by social risk factor population against national benchmarks, compare social risk factor percentages to national averages to determine reward eligibility, and estimate the contract's health outcomes based on measure performance and plan composition. Keep in mind, CMS may also consider additional changes regarding the EHO for All reward, but any further changes would need to be proposed through rulemaking. There were no new updates to these changed measures for the Star Year 2027 program. To recap what we know about the previously codified rules, the age range for colorectal cancer screening has been expanded to include adults ages 45 to 49. A statin intolerance exclusion has been added to the statin therapy for patients with cardiovascular disease measure. The 2 new HOS measures improving and maintaining physical and mental health have increased the measure weight from 1 to 3 weighted. and the hybrid reporting has been removed for the CDC eye exam measure. This measure will be administrative reporting only. There were no new updates and/or changes for these measures for the STAR Year 2028 program. To recap what we know about the previously codified and proposed rules, the following rules remain codified. The removal of the non-risk adjusted medication adherence measures, the addition of the risk adjusted medication adherence measures with a weight of 1, and then the following rules are now deferred and remain uncodified. The removal of statin therapy for patients with cardiovascular disease measure, the removal of guardrails for non-CAPS measures, and the addition of initiation and engagement of substance use disorder treatment measure as a weight of 1 and as an average of initiation and engagement rates. The addition of the initial opioid prescribing for long duration measure with a weight of 1. There were no new updates and/or changes for these measures for the STAR Year 2029 program. The following rule remains codified. The adjusted medication adherence measures increase from a weight of 1 to a weight of 3. And the following rules are now deferred and remain uncodified. The modification of the improvement measures hold harmless policy to only apply to 5-star plans and, if applicable, for the highest rating to be determined based on the rounded rating before the addition of the EHO for all. The clarification of the technical specifications for excellent health outcomes for all related to enrollment calculations, ISNP contracts, and the addition of geography as a social risk factor. You may recall CMS may also consider changes regarding the EHO for all reward, and any further changes would need to be proposed through rulemaking. So it's unsurprising that no clarifications were announced at this time. Breast cancer screening was the only substantive measure change finalized for the STAR Year 2029 program. Many of the measures have been identified for transition to ECDS reporting starting in measurement year 2027, while the remaining measures have been identified for substantive measure changes. Specifically, for breast cancer screening, CMS finalized the change to expand the age range for the breast cancer screening measure to women aged 40 to 49, and for an updated age range of 40 to 74. CMS considers a change in the denominator's age range be a substantive change, meaning the new range needs to be adopted through rulemaking. Measures with substantive changes must be on the display page for 2 years before they can become part of the STAR ratings program. As such, the BCSE expanded age range will only be on the display page for measurement year 2025, STAR year 2027, and measurement year 2026, STAR year 2028, before officially becoming part of the STAR ratings program in measurement year 2027, STAR year 2029. In the meantime, the existing BCSE measure, ages 52 to 74, will remain as part of the STAR ratings program. Aside from breast cancer screening, no other changes have officially been codified. However, we will keep you informed and share any updates as more details become available. Thank you.
Thank you for taking us through those updates, Danny. So as I look at those screens, I saw a lot of pink. To recap, there was only 2 proposals that were codified. That was the expanding of the breast cancer screening age range and renaming the Health Equity Index. Nothing changed with the calculations of the index itself, just the name of it. So out of all of the changes that were proposed back in January, there were truly only 2 things that were codified. What does that mean? How should plans interpret that large number of deferred proposals? Let me add a little bit of context before answering that question. So as you know, the outgoing Biden administration published the advance notice early this year. That allowed them to set the proposals in January before they left office. That means that the incoming Trump administration did not have the chance to set any of those proposed changes. Back in February, Robert F. Kennedy Jr. became Secretary of the Department of Health and Human Services. And in the beginning of April, Dr. Oz was named the new administrator of the CMS. Each of these men has their own priorities and visions for how they should lead their respective organizations. As they were just confirmed into their new roles recently, they really haven't had a chance, the time yet, to thoroughly review all of the proposals and decide what needs to be kept, changed, or removed. So, with that context in mind, let's answer the question: how should plans interpret the large number of deferred proposals? To put it simply, more changes are expected, they just haven't happened yet. How might CMS implement additional changes then? That might be the next question that you're thinking. Let's review the options that they have available to them for codifying new rules. So there's 3 different methods that CMS can use to make changes to the star ratings program. The first is propose and comment, then interim final rules, and finally direct final rules. I'll go through each of them at a high level on the screen. So first, propose and comment is the method we're all probably most familiar with, as it's historically been the one used most often by CMS. In this method, CMS outlines the proposed changes and the rationale behind them in the notice of proposed rulemaking. That was the advance notice, like the one that we received in January. Then stakeholders, including healthcare providers, insurers, and the general public, are given a specified period of time, usually 30 to 60 days, to provide feedback on the proposal. And then finally, CMS reviews the comments, makes any necessary revisions, and publishes a final rule. Now, this approach allows for public participation and transparency, enabling the agency to consider various perspectives and potential impacts before finalizing the rule. But the public comment period means that it takes a longer period of time to finalize new rules using this method. So an example of this would be the advance notice and final rules, like the one that we used just this year to propose the changes in January and then finalize them in the final rule in April. The next method is the interim final rule. These are used to implement a rule quickly, often in response to an urgent situation or statutory deadline. So in this method, CMS issues an interim final rule, which means it goes into effect immediately upon publication. However, there's still a period post-publication when stakeholders can still submit comments. So CMS is supposed to review all of the comments that come in, make any adjustments before issuing that final rule or modifying the interim rule. So this approach allows CMS to quickly and more flexibly address urgent needs while still providing an opportunity for public input afterwards. And there's a lot of examples of interim final rules in CMS's response to, for example, the COVID-19 pandemic. If you remember, CMS covered the COVID-19 diagnostic testing. There was a lot of expansion to telehealth so that we could continue to receive treatment while avoiding any potential exposures to the virus. And then I'm sure we all remember the changes to the Part C and D star ratings, how we could take the higher of, the better of measure rates across the 2 years when it wasn't possible to gather medical record charts in person during the pandemic. So interim final rules are used to implement changes quickly, often in response to urgent situations. And then finally, direct final rules are the last choice that CMS has to implement rules. They're meant for non-controversial updates and changes. So in this method, CMS publishes the direct final rule with an effective date. There's no comment period. There is a comment period of 30, 60 days. And if there's no significant adverse comments received, the rule becomes effective as planned. If significant adverse comments are received, then the agency will withdraw the direct final rule, before it becomes effective and may opt out to issue a proposed rule instead. So this approach is great for avoiding the lengthy process of proposing and commenting. However, it doesn't allow much opportunity for public comment and feedback from stakeholders. Some great examples of these are the routine kind of keep the lights on technical changes that are non-controversial and unnoteworthy to the public. Things like removing references to expired programs or updating reporting requirements or updates to payment rules. So as you can see, there are different avenues that CMS can use for rulemaking, all of which are suited for different situations. Just because we didn't see many changes in the advance notice and final rule doesn't mean that we shouldn't expect the star ratings program to change. Industry leaders are expecting CMS to utilize the interim and direct final rules avenue more heavily because they enact quick changes that depend far less on the public comment period. Since the administration changed in January, new guidance and new legislation impacting industries across the board have come fast and furious. And CMS is on a similar path for the same type of rapid rulemaking. We're expecting to see less propose and comment and more interim and direct final rules. So how do we prepare for changes if we don't know what changes are coming? How do we set a strategy and make investments if we don't know what the rules will be? In the absence of those final rules, such as the case that we're in today, we can look at the agendas and directions set by the new administration to date. While we might not know the specifics, we can gather a sense of their general direction. Let's take a look at what we do know. Dr. Oz outlined the following goals for CMS during his first Medicare agency town hall at the beginning of April. Dr. Oz emphasized the shift towards a healthcare system that prioritizes prevention, wellness, and chronic disease management rather than solely focusing on sick care. This aligns with RFK Jr.'s goal of making America healthy again. The message is clear. They want to prevent people from becoming sick or sicker in the first place. Dr. Oz has also expressed a strong desire to modernize CMS's systems and tools with the goal of streamlining processes and allowing doctors and nurses to spend more time on patient care rather than paperwork. This likely includes leveraging technology like AI to improve access, efficiency, and potentially personalized care. The aim is to reduce the administrative burdens for healthcare providers and allow them more time for focusing on patients. Another significant part of Dr. Oz's agenda involves aggressively identifying and eliminating fraud, waste, and abuse within the Medicare system. There weren't a lot of specifics given in this area, but a reduction of fraud, waste, and abuse can only lead to positive changes, such as extending the solvency of the Medicare Trust Fund. Finally, Dr. Oz aims to provide Medicare beneficiaries with better tools and more transparency regarding their health care. He wants to give individuals more control over their health and the ability to navigate healthcare systems effectively. As a first step, he plans to focus on providing clarity around costs, which is in line with the president's executive order on transparency. So, as I said earlier, this isn't as good as having specific rules to follow and implement, but it can give us some of these themes to focus on. So based on those themes, I've created 4 areas for plans to focus on to set themselves up for success. First, focus on whole member care. We tend to look at measure lists, right? Breast cancer screening or a med adherence list, because that's the way that our data is structured. And as such, we tend to work on one measure at a time. Instead, it's really important at this juncture to shift the paradigm and ensure that you're looking at a whole member. If you aren't already, find ways to get all of the member information together to inform your outreaches and interactions. Make sure you're looking at things like all of the measures that a member qualifies and what their compliance is. What type of socioeconomic information do you have for members? Look at outreach campaigns involving that member so that you can get a full sense of what's going on with the member and what the health plan interactions are with them. Understand what's preventing your members from achieving compliance and remove those barriers if you can. Do they need education on how to manage chronic conditions or take their medications? Do they have a transportation issue that's preventing them from getting to their appointments? Or would they benefit from a telehealth appointment? Are they having trouble paying for their medications? You also want to perform proactive outreach to customers even when they aren't having issues. Don't wait until there's a big issue like a hospitalization. Helping with those smaller problems can avoid the bigger issues in the first place. It also helps open those lines of communication so that members do outreach when there is an issue, or to know what supplemental benefits are available to them when they do have a problem. These outreaches go a long way towards improving or maintaining your member experience measure scores as well. The next thing that you can focus on is outcomes. In the advance notice, CMS signaled that they want to move away from measures that focus on operational performance or completion of administrative processes. Instead, they want to move towards measures that focus on clinical care, outcomes, and patient experience. Which specific measures remain and retire are still up in the air, but regardless of the direction, it's always a good idea to focus on areas like outcomes and patient experience. Here's some examples of what I mean when I say focus on outcomes. 1, ensure that you have all the processes in place for good outcomes when a member is discharged from the hospital. Do they have a follow-up visit scheduled with their PCP? And can they get to their appointment? Do they have a clear understanding of the meds they should be taking? Do they need help at home for activities of daily living? 2, ensure your members are educated on their chronic conditions. Can you help members monitor their blood pressure or their blood sugar at home with some at-home monitoring tools so that they are alerted to issues before they become complex adverse events requiring hospitalization? And 3, do supplemental benefits actually help members achieve their health goals? Do members need a silver sneakers benefit, or would a grocery voucher or a transportation voucher be more useful to them? Make sure that your benefits match your members' needs and help them achieve healthy outcomes. Next, focus on innovation. We all know about the push to digital measurement and interoperability. Is your organization ready for it? This is the time to push for that digital transformation and technological advancements, as these projects require a long runway for implementation. Plans who build that technical infrastructure are going to be able to make data-driven decisions that allow them to work smarter, not harder. I read an article just yesterday saying data is power. With good data, you'll be able to do things like analyze supplemental benefit usage and cost, determine the ROI on your outreach programs, and inform your P4P payment arrangements to recognize those outstanding provider performers. Investing in good data will help your organization innovate and grow in the right areas for continued success. And finally, focus on listening. Stars leaders really need to keep an ear to the ground right now. Make sure that you're linked in with CMS and other thought leaders in this space, or regularly tune into webinars such as this one to stay up to date with the latest changes. If the new administration leans into those interim and final rules as expected, then STARS leaders need to be on the lookout for changes outside of this usual propose and comment cycle. When you find out changes, socialize them with your stakeholders and listen to their concerns. Also, listen to ideas that come back from your stakeholders. Your teams are the experts in their respective areas, so don't dictate to them. Instead, get their feedback on obstacles and opportunities and make sure that you're keeping everyone up to date. So this was a very tricky advance notice and final rule. It definitely didn't follow the pattern that we're used to seeing. At a surface level, you might think that this final rule was uneventful because it didn't contain many changes. But we encourage plans to stay tuned in to thought leadership so they're up to date once changes are announced. Even though we don't know the specifics of the STAR ratings program changes, it doesn't mean that plans are stuck or unable to move forward. We know the general direction of CMS under Dr. Oz and those key themes that he wants to accomplish during his times in office. So based on those themes from Dr. Oz, I presented 4 areas of focus to use as your framework moving forward. Focus on whole member care, outcomes, innovation, and listening. In many ways, those areas of focus that I offered today represent, I'll call it a back to basics approach that will help your plan succeed regardless of the changes that are coming to the STAR ratings program. Well-rounded, proactive care is always a good idea for keeping members happy and healthy. Setting members up for good outcomes will always lead to better care. Investing in good, complete data will always help make informed decisions that put members first. And listening to our stakeholders will always help us make the best decisions with the specific needs of our organization in mind. So thank you for your time and attention today. With that, I'll turn it back over to Cassie to wrap us up.
Thank you so much, Marge and Danny. This was great information. We know these key dates and all of the details that Marge and Danny went over can be often tough to track. So before we close today, I do have a couple of resources to share if you can spare an extra minute with us. I again welcome you to scan the QR code on your screen to download Cotiviti's CMS Star Ratings calendar as a reminder of proposed and confirmed changes to the CMS Star Ratings program. A reminder that we keep this calendar consistently updated all throughout the year, so you can always bookmark this tool for an up-to-date reminder of proposed and confirmed upcoming changes to the CMS Star Rating system. Next, here is a QR code to register for the other webinars in the Quality Decoded series, featuring Marge, Danny, and other experts from Cotiviti's Quality and Stars team. If you haven't already, you can register for any or all of the rest of the series or view those that you may have missed on demand. And lastly, if you submitted any questions during Marge and Danny's presentation, your Cotiviti account team will follow up as appropriate. You can also send an email at any time to answers@cotiviti.com for any additional questions or for more information.